All right, my friends. What an interesting topic in 2016, right? I start with a question. Does malnutrition even exist? I said 2016 in 2026. Is that a fact or a fiction? And I'm going to talk about telltale signs of malnutrition, specifically in our senior population that you don't want to miss. Okay. And this comes from it comes from a lot of discussions over the last couple of months. It comes from continuing ed that I've been doing in autoimmune disease. It comes from personal experience in taking care of my primary care patients, and it comes because of consulting relationships that I have with each of you. So I'm going to share some of those experiences today. We're all aware that recently there was talk about a humanitarian crisis in Gaza as the war in the Middle East between Israel and Palestine and Iran and Gaza and all these areas were embroiled in conflict. Many of the people became displaced from their homes and life stood still, and they lack food and nutrition. And so there was a lot of talk, and it was named this humanitarian crisis. Okay. So it's easier to see maybe where there can be some malnourishment that happens in third world countries. Much more difficult to see could that be happening in our area, in the United States per se. And so I want to share a clinical case from this week. Now, I had already prepared this presentation when I experienced this clinical case, but I want to share it because it applies so much. It applies very well. I have a 74-year-old female who's generally quite healthy in my practice. My primary practice is it's almost exclusively a Medicare practice. I would say 90% a cognitive impairment practice for people with dementia, okay, or people who want to avoid dementia. I'm not afraid to take Medicare clients. The insurance reimbursement isn't as good, maybe as other payer sources, but this is where I've made my love and my clinical experience. So I saw this 74-year-old woman. I've taken care of her for several years, and she is a chronic fatigue sufferer. Long history of chronic fatigue. Recently, maybe in the last year, she's experienced this intermittent vertigo, and she has a diagnosis of Meniere's disease. We've sent her to cardiology. She's had high blood pressure, so that's one of the few medicines that she's currently taking. We've sent her to multiple specialists to try to figure out how to help her feel better, wondering if her symptoms were cardiac related. Long history of chronic fatigue syndrome that I'm going to talk about. And it's starting to wear on her. When you don't feel well for a long time, you have an illness plus a mood disorder. You're kind of depressed, you kind of don't feel very good. Okay. So you start getting discouraged. Last year she had a son that experienced a DUI. So there was a lot of emotional stressors. Every parent who has a child that has an alcohol problem and then has a DUI, man, that's just a huge stressor for parents. So I often thought that maybe her chronic fatigue syndrome was related to the fact that she's stressed out all the time because of adult children. And yet I thought, well, maybe she has sleep apnea. So I'm going to get her tested for sleep apnea. And I sent her in as one of her referrals. She falls asleep just fine, but she cannot stay asleep. She wakes up every morning about 3 o'clock, sometimes a little earlier, sometimes a little bit later, and cannot go back to sleep. She's just wound tight. She's 5 feet 6 inches tall and she weighs 130 pounds. Now, when I was visiting with her, I said, "What's your approximate weight? Are you about, 150?" And she was wearing a coat. It's cold in Idaho, so she's wearing a coat and some baggy clothes. So I estimated her to be about 150 pounds. Well, she let me know how irritated she was. And I know better. I should never try to guess someone's weight because if you guess over by 1 pound, you're screwed, right? This was a problem that I did. So I guessed her at 150 pounds, and it was amazing how irritated she grew with me. When I asked her about diet, the conversation started to open up. And she says, "Well, Randy, I'm an intermittent faster. In fact, some days I eat about 1 meal per day. That's an eating style that we call OMAD, 1 meal a day." Okay. And I thought, I wonder if this is part of her chronic fatigue syndrome. And I said, "Well, tell me about your daily pattern. What do you do?" And she says, "Well, I told you I wake up every morning about 3 o'clock. I can't fall asleep. I'll get up and tootle around the house until I finally decide I'm going to exercise. And I go walk 10,000 steps every day. It's usually sometime between when I wake up and about 11 o'clock in the morning. And she was so clear about 10,000 steps. Now, for those who know me, you know I'm a walker. I walk a lot. And I said to her, wow, if I walk 10,000 steps, I usually walk at about 4 miles per hour, and I can walk 10,000 steps. It usually takes me about an hour and 20 minutes to get 10,000 steps, and that's about 5 miles. And she says, yeah, it takes me a little longer than that. It takes me about an hour and a half, maybe a little bit longer. And I said, and you do that every single day? Yep. And I said, and you intermittently fast, like you don't ever eat breakfast, but you're giving an hour and a half of exercise, 10,000 steps every day? Yep. And I said, oh, interesting. Well, when you get home from your walk, do you eat lunch? And she says, no, I told you, I don't know, maybe I'll have a snack, but I'm so exhausted that I require a nap every day in the early afternoon. And I said, well, that's interesting. Do you fall asleep quickly? Yes. How long do you sleep? Maybe 30 minutes. And when you wake up, do you eat something? No, Randy, I told you, I typically just eat 1 meal a day. Occasionally, if I'm really hungry, I'll eat 1/4 of an avocado. I'll say, oh, why only a quarter? Because it has too many calories and I don't want to get fat. I said, oh, now it's starting to get clear to me. You can tell by my presentation of talking about malnourishment in the senior population. I would propose that this lady is 100% malnourished. She's eating an inadequate amount for her needs, and that's the answer to her chronic fatigue. When I proposed that to her, again, she was more irritated and frustrated. She didn't want to hear it. I am not malnourished. I get plenty of food. I don't need that much. And by the way, when I eat, it makes me hungry. Appetite, when I eat, it stimulates my appetite, and I don't want to be stimulated. There's the framework for my conversation today. Pretty interesting. In the world that we live in, we have studied calories for 50 years. Weight Watchers was born on calorie restriction. Weight management is built on this concept that if you want to lose weight, you have to restrict your calories. I'm telling you this because the world we live in looks at food from a calorie perspective, not necessarily a nutrition perspective. Many of you on our call today run assisted living centers, and I assure you that the diets that you have written by your dietetic experts and they fill your menus, these are based on calorie amounts, not nutrient amounts. And you can see by this graphic that you can get 1,800 calories in a shake, a burger, and fries, and that nutritional content is very different than if you look at the 1,800 calories next to it. Remarkably different in the nutrient levels, but the calorie load is identical. Okay? So start thinking of this. Are you focused on calorie loads to the point that your diet is a junk food diet and you're missing the health foods? Now, if I go back to my initial discussion, we're talking about malnutrition or malnutrients or inadequate nutrients in our senior population. Why? Because the majority of them have been eating TV dinners, processed foods, junk foods, pre-prepared foods with a very low level of nutrients, in spite of the fact they're probably calorie adequate. Calorie adequate does not mean nutrient adequate. Okay? So malnutrition almost seems unfathomable in 2026. And it's for the reasons I just shared with you. We're focused on calorie counts and not nutrient counts. We live in a society that's completely overfed and totally undernourished. Let that sink in a little bit. Can an individual be obese and malnourished? You would almost say you can't because you're thinking back in the days when we heard about Ethiopia and the droughts and the starvation. And these kids and these adults that are whittled down next to nothing, that's the image that we have in our mind of being malnourished. We don't have the vision of morbidly obese individuals with BMIs of 40, huge bellies, obstructive sleep apnea as individuals who are malnourished. And I'm proposing that they are completely malnourished on many levels. That's not just a supposition I'm making. I practice medicine. I have been now for many years, and I've taken care of thousands of individuals, and I have checked their nutrient levels for years. And I can vouch for the fact that they can be obese and totally malnourished. We're focused more on the quantity of the food that we eat, not the quality of the food. I have a dear friend that lives close to me, and we had a standing appointment each week on a day I wasn't seeing patients that we would go to lunch. And he would pick and I would pick. And I watched this trend. I would say, let's go to this restaurant today. And he would say, no, I don't want to go there. They don't give me enough food for the amount of money that we pay for. He was focused on the amount, the quantity of the food, and I was focused on the quality of the food. We talked about this all the time. And he would say, quality schmality, Randy, you're overrated. I'm hungry. Let's go get some food. And so today I want to talk about the difference between generalized guidance from a nutrient standpoint, and I want to compare that to a personalized guidance pattern, especially in our seniors. Okay? This was a totally awesome book I read last year called High Calorie Malnutrition was part of the title. The author of this book was a pediatrician at the Cleveland Clinic and one of the foremost experts in B vitamin deficiencies in pediatric patients. Now imagine that, pediatric patients having B vitamin deficiency. We're talking about seniors. Good grief, if they're starting with problems in their pediatrics, it just is perpetuated into our seniors. Okay? So I'm going to spend the rest of my discussion talking about signs of malnutrition in our senior populations. These seniors that you take care of, our parents, our loved one, my clients. We're going to talk about this. I'm going to talk about how you can tell or how you get insight into the fact that these individuals might be malnourished. So the physical signs would be unintended weight loss. How about seniors living in your communities or your mom and dad that lose weight? They're not trying to lose weight, but their clothes are getting looser and looser and their muscle wasting, their strength goes south. They have tremendous muscle weakness. Now they can't get out of a chair without a hydraulic lift, lifting that lazy boy to a standing position so they can stand up. They can't roll over and sit on the edge of their bed and go from a lying to a sitting position without a Hoyer lift. This is muscle weakness in its finest moment, and it's a physical sign they're malnourished. I just shared with you my case example of the woman, 74 years old, with chronic fatigue syndrome and low energy, who's in a fasted state most of her life, has to take a nap because she's wasted and exhausted all day long. She's sleeping more than she should from her perspective, right? How about dry skin, brittle hair, and hair loss? Do you know how often I have women that come to me and say, gosh, I'm losing my hair. How can you prevent this hair loss? Is there a medicine? Not even a forethought as to what's going on with their nutritional status. And frequent infections. How about everyone that says, oh, I get the flu 2 or 3 times a year. I get pneumonia. I'm always sick. I always have a cough and congestion, and I have slow healing wounds. These frequent infections are physical signs that they are malnourished in one way or another. Let's talk about the behavioral symptoms and signs. So number one, how about people who say, I'm going to skip a meal? I'm going to choose not to eat. The lady I just shared with you only eats 1 meal a day because somewhere in her social media feed, she was told that intermittent fasting is the rage and she needs to intermittent fast. And yet she's very lean and very thin and she's exhausted all the time. That's a bad decision, in my opinion. That's where these guidelines about how to eat and how to be healthy fail individuals because We talk that everyone should be an intermittent faster. That's nonsense. Everyone shouldn't be an intermittent faster. Individuals who eat really small portions, where they kind of pick up their food, they push it around their plate. You go pick it up and it looks like they ate, but they didn't eat very much. How about our seniors that have difficulty chewing or swallowing, right? If our seniors have had a stroke, they don't swallow well. Some signs of dementia, they lose their ability to swallow. They cough every time they try to swallow. Maybe they have dentures or they have bad teeth. They have dental decay, and so they just can't chew the same. Eating a steak is a pipe dream because they just can't chew a piece of steak. Some people say, I'm really not interested in food. I don't feel hungry anymore. My 74-year-old patient says, look, I'm not interested in food because if I eat it makes me hungry. Well, that should be a sign. Maybe your body's telling you that's a light on your dashboard. You should eat something. Individuals are also fixated on only one or two foods. This is very common in my patients who are younger. They have very restrictive diets. Don't make me eat a fruit or vegetable. I don't like the texture. I rely on mac and cheese, top ramen, and Pop-Tarts, baby. I'm fixated on one food. Or I like TV dinners. I like processed food, chicken nuggets. I want something that I nuke in the microwave that's fast and easy. I don't want to prepare a meal for one or two people. So we resort to processed foods. Processed foods diet are almost a guarantee that they're going to experience malnutrition, malnutrient levels. And how about if they drink alcohol? Alcohol is largely given a pass in medicine. It really bothers me that we say, well, I just have 1 glass a day or 2 glasses a day. Do you know that alcohol is a contributor of the 5 most common cancers in America? Modifiable definitive risk factor. I think that this chronic, persistent 1 to 2 glasses of alcohol a day does more damage than we get it credit for, not to mention those who binge drink on a regular basis. Alcohol consumption robs our bodies of nutrients. And today I won't spend a ton of time talking about that, but I certainly could if you wanted to. Okay. How about the cognitive signs or the emotional signs that a senior may be malnourished? Well, they're generally increased, confused, or agitated. If you have a senior that just year after year and day after day gets more and more demented over time, and you're attributing it to age, you're missing something, right? There might be something that you could do about that. How about our seniors who are progressively depressed? They have apathy or social withdrawal. Maybe you should focus on nutrient levels and see if that could come back. Excuse me. How about our seniors who have difficulty using utensils, or they don't really recognize mealtime and don't recognize foods? They're just kind of emotionally disconnected because there's so much dementia there. That might be a sign. Let's talk about digestive or signs of hydration issues. Seniors who are chronically constipated or who have repeat diarrhea probably have some sort of a malnourishment issue. Isn't it interesting that one of the ways we treat diarrhea is we give the nutritional supplement magnesium? That's how we treat constipation. That's fascinating, right? Maybe constipation, a sign of constipation is low magnesium. I just sent an article to my team that low vitamin B1 is a predictor of irritable bowel syndrome. And just improving vitamin B1, which is thiamine, can improve bowel patterns. So how many of our residents or our patients or our seniors have irritable bowel syndrome or inflammatory bowel disease? You could take that as a symptom or a sign that they may be malnourished. Constantly dehydrated with dark urine or dry mouth or dizziness. Maybe they have bad breath and terrible dental health. We talked about that, dental decay. That might be something that impacts their ability to put food in their mouth and chew it up and swallow and digest it. Maybe they get mouth sores or eating becomes uncomfortable because they have ill-fitting dentures or they have limited use of dentures. I know a lot of seniors who have dentures and never wear them because they don't fit anymore. They've lost 10 pounds and they just don't feel good in their mouths. Well, we're also a society that follows lab signs. What are the laboratory signs of malnourishment? I want you to pay close attention to this because I want you to think, if we have a senior go get labs, what lab work might clue us into the fact that they're undernourished? They don't have enough nutrients. The first one is albumin and prealbumin levels. Now, it's interesting. I think that primary care doctors typically don't pay attention to these from the context of malnourishment. And do you know that the protein requirements of seniors actually go up as they age, not going down? We think that the bodybuilders that go to Gold's Gym every day are the ones that need high amounts of protein. It's the individuals, by the way, those guys are probably all overdoing it. It's the individuals that need a chairlift to get them out of a chair because their muscles are so weak. These are the individuals that are malnourished from a protein standpoint. We pay attention to their white blood cell count. Individuals who are malnourished have low white blood cell count. It means their immune system is shot. They get sick all the time. We pay attention to hemoglobin and hematocrit and MCV values. My good friend Eric Colette can interpret an MCV value better than 90% of primary care doctors because he's looked at thousands of these labs and correlated it to patients. MCV levels are a almost perfect predictor of individuals who either have iron deficiency or vitamin B12, folic acid, and thiamine deficiency. You can see it instantly. And so many primary care providers see an elevated or a low MCV value. And if it's just mildly elevated, they're like, it's probably just because you're old. No, it's because you're old and malnourished. Omega-3 status. Ask yourself, how many of your seniors have had their omega-3 levels checked? Do you know that there's been tens of millions of dollars spent looking at healthy levels of omega-3 for the entire population? And it is a massive predictor of cardiovascular health. And yet we don't even check those levels on a regular basis. It's crazy. Did you know that there are 2 omega-3 supplements that are covered by insurance? One's called Lovaza and the other one's called Vasipa. And it's because they lower the risk of cardiovascular disease. But we don't check those levels. I can't figure it out. It's lost on me. B vitamins are so important. There's about 8 or 9 B vitamins, but the ones that seem to have a direct tie to reversible cognitive impairment are vitamin B1. Vitamin B1 is thiamine, vitamin B9 is folic acid, and vitamin B12 is called cobalamin. Okay? Directly correlated, not indirectly, not kind of through this weird, it's 100% directly correlated with cognitive impairment. And when low, that can be reversed. That whatever level of cognitive impairment they have associated with those B vitamins gets better when we utilize them. Iron studies. Now, fortunately, we live in an environment where doctors will actually check an iron level. But when's the last time your doctor checked your vitamin B1 or your folic acid level? They don't hardly ever check it, but we check iron. I don't know why we check some and we don't check others. It's crazy to me. Fat-soluble vitamins. We check vitamin D, but we don't check vitamin E very often. Why wouldn't we? Vitamin E is a known antioxidant directly linked to cognitive status. Vitamin A and vitamin K, omega-3s, these are all fat-soluble vitamins that make a huge difference. Copper and zinc and magnesium and selenium levels. When was the last time your doctor checked your zinc and your copper level? Or your magnesium RBC, not serum mag. Serum mag it doesn't change very much unless you're wildly deficient, but magnesium RBC gives you a range that's kind of predictable with what your tissue level of magnesium is. Serum selenium, boy, we check it on all the time. It's very often quite low in our seniors, directly tied to thyroid function. Selenium directly tied. You got any senior with thyroid issues, selenium ought to be a part of a thyroid panel. We look at cholesterol levels very often, and we look at them and tell people to lower their fat, but we don't pay attention to that triglyceride levels is actually probably one of the better predictors of too much sugar in the diet and insulin resistance. We pay attention to electrolyte status, thank goodness, right? And part of the reason we look at those is because so many medicines minimize their sodium and potassium levels. So we're kind of obligated to follow these because they're on diuretic medicines or blood pressure medicines like ACE inhibitors and angiotensin receptor blockers that actually change these levels. So we have to stay focused on them. And then we focus on their blood sugar levels. What's their serum glucose or their A1C or insulin levels? These would be laboratory markers of a nutrient deficiency that otherwise goes missed unless we're checking for those levels. So let me explain other factors that I haven't yet talked about. Nutrient deficiencies, when they start getting low, spiral into a sickness. So how do you know you have these? Well, I already talked about the fact that we live in a processed food nation that's completely nutrient depleted. And we get tricked into thinking, well, if it's fortified, if the food industry artificially adds a little bit of vitamin B1 and vitamin B9, then it's been fortified. Or if we put a little bit of vitamin D in milk, then it's fortified, it has an adequate amount. You need to just forget about that. Fortified does not mean that it's adequate. It means that you're barely hovering over the diagnostic component where it's nutrition and actually leads to disease. High sugar diets completely deplete nutrients. Why? Because you fill up on foods that are vacant of any nutrient status. Our society lives on soda pop. We live on potato chips. We live on candies. We express our love during the Christmas holiday by giving junk food to people, which is loaded in sugar and loaded in calories and completely deficient in omega-3s. In fact, did any of you give a can of sardines to your loved ones for Christmas and say, I love you so much, I want your omega-3 level to be elevated, so I'm giving you this can of sardines? Of course you didn't. You gave them peanut brittle, which is loaded with seed oil and sugar and salt and has absolutely no nutrition in it, okay? And then we toast each other after the new year and we have a little bit of alcohol, which is alcohol and sugar combined. We get a little tipsy and there's zero nutrition in there, and then it impairs the liver and actually causes inflammation in our bodies. Well, that spirals into sickness. Some people have genetic problems. They have SNPs. SNP stands for singular SNP, singular nucleotide polymorphisms. And they minimize our ability to absorb vitamin B12, like the SLC119A, or the thiamine transport protein, or some of the genetics that minimize vitamin D. And then we take medicines that block these. Did you know that Metformin, one of the #1 medicines used in diabetes, actually blocks vitamin B12 and folic acid and vitamin B1 from being absorbed in the body? Did you know that statins, one of the #1 prescriptions in the world, minimize CoQ10, which we need for energy production? It depletes CoQ10, actually. In Canada, it's on the warning label. Many of our medicines have anti-nutrients in it. Methotrexate, which is very commonly used for autoimmune disease, functions by blocking folic acid from being functional. That's how it works. That's its mechanism of action. Or the anti-nutrient impact of acid reflux medicines that we call PPIs, that purple pill, omeprazole, pantoprazole, Nexium, Dexilant, Acefex. These medicines actually block the absorption of nutrients in the GI tract. It's on the warning label, okay? People who have malabsorption disorder, they eat and everything they eat goes right through them. They got diarrhea or irritable bowel and they're bloated. I just sent my team an article this morning about how vitamin B1 is a potential treatment for irritable bowel because vitamin B1 has such a powerful mechanism of action to strengthen the GI tract. And then the last one is the more stress we're involved with, the more infection we get, the more nutrients we need to try to overcome illness. Nutrients are involved in the production of energy and protein synthesis and ATP production. And so without them, we don't recover well from illness and infection. And so we end up being like my 74-year-old patient that says, I'm so tired I have to take a nap every day. I just have chronic fatigue. And then heart disease is the #1 killer in large part because of these challenges. Or people say, I get this mysterious disease called peripheral neuropathy, and we don't even know what causes it. We just know that half of our seniors can't feel their feet anymore because their nervous systems are whack. They have GI disorders like crazy. I can't believe the number of my primary care patients that have acid reflux, irritable bowel symptoms. They bloat, they're constipated, they have diarrhea. I wonder if they're malnourished. Or remember, I'm the brain guy. They have neurological disorders that are contributory to these. I've been doing a continuing education lecture series from this excellent practitioner. And she talks about how autoimmune disease is driven in large part by diet. And she says that when we eat this diet of processed high sugar foods, it actually turns on a dysfunctional immune system response. We get these pro-inflammatory adipokines and cytokines. You remember from COVID, everyone talked about a cytokine storm where you have these inflammatory markers that go crazy. Well, that's what processed food does. It amplifies pro-inflammatory cytokines like interleukin-6 and tumor necrosis factor alpha, interleukin-1b. Okay? She goes on to talk about all of these complexities in our bodies where our pancreas stops working right and our immune system stimulates macrophage production. We start getting high blood sugar. It's creeping up, and now we're diagnosed as insulin resistant and pre-diabetic. And then those inflammatory cytokines go up. We just talked about that. And we start living in a constant state of low-grade inflammation because NF-kappa B is now through the roof. NF-kappa B is a modifiable risk factor in dementia and all forms of cognitive impairment. Not to mention atherosclerosis is the #1 killer nationwide from cardiovascular disease. All of these have a direct tie to how we eat, how undernourished we are because we're overfed and undernourished because of the great American diet. And we all run around with oxidative stress. That's what that increased reactive oxygen species are. So Robin Puglia is this expert in autoimmune disease that I've been doing continuing ed with. And she says that the great Western diet predicts chronic inflammation because these high amounts of energy-dense foods, which is this processed manufactured frankenfoods, they damage the saturated fats and these refined carbohydrates that eat, high in sugar, low levels of nutrient-rich foods, right? We're not getting enough fruits and vegetables and fibers. We don't get enough fatty acids like olive oil and omega-3s. We don't get good antioxidants like vitamin E and glutathione and selenium and vitamin C. And all of these things lead to chronic activation of our immune system, both innate and adaptive, and lead to a chronic state of inflammation. It's a predictor of dementia and heart disease. Okay? So for all of our assisted living directors and our community directors who are here today, sometimes I hear this statement, hey, we just let our seniors eat whatever they want. They can eat whenever they want. They get to pick. They can have dessert for breakfast or lunch or for dinner. They can have as much soda pop as they choose. They want root beer, they can have it. They have earned the right to live their life and eat how they choose to eat, live how they want to live. And my response to that is, where are the guardrails? To me, that's the equivalent of I have a teenager and I say to my teenager, hey, listen, you're a good kid. I don't care how late you stay out at night, whether you go to school or do your homework. I don't care if you smoke pot and experiment with alcohol on the weekends. You live your life. You're a good kid. No, we live in a society of guardrails, of safety mechanisms, that we recognize that when we stay within these bounds, we do better. So I'm giving you this because I want you to have education. I want you to know that the way that you prepare and educate and teach our seniors about the difference between malnourishment and dementia and calories and how we prepare our meals, that becomes predictive of how they're going to age. Are they going to age and absolutely fall apart? Or are they going to age and they'll just kind of be pleasantly confused? We may not fully get rid of their dementia, but they're not going to be kicking our staff members and biting. And then every little while, we got to run them to the emergency department, which you all know. They go to the ER, they do a $10,000 worth of tests, they call us back and they say, hey, they're just old. There's nothing we can do, but we're going to add this antipsychotic so they don't bite your caregivers anymore. Oh my gosh, you can see where I'm going here. The Journal of the American Medical Association posted this article that said there is an association between the consumption of ultra-processed foods and cognitive decline. This came out 18 months ago, okay? The conclusion and the relevance of this study showed that there is a higher percentage of daily energy consumption when ultra-processed foods are used, and it's associated with cognitive decline. These findings support, listen to this, this is the last statement. These findings support current public health recommendations on limiting ultra-processed food consumptions because of their potential harm to cognitive function. Okay? So, my take-home message is I believe that terrible behaviors in advancing dementia is directly related to malnourishment, malnutrition. And yet, when we have our advanced seniors, we call the doctor, and the doctor doesn't say, oh my goodness, we need to look at all their nutrient levels and optimize them. The doctor says, well, guess what? We better start an antipsychotic and a mood stabilizer and an antidepressant because we think that these pharmaceutical agents are going to make their life better. Wrong. They never make their lives better. They always make it more complex. Why? Because now we get bad side effects. Generally speaking, these are associated with poor outcomes in our advancing seniors. They have continued decline. And every time they have continued decline, we have to have this emergency. Call the doctor, get a new medicine. Let's send them to the emergency department. Your mom and dad can't live in my community anymore because they're mean to my caregivers. They have to go to somewhere where there's more staff, where there's more help. My gosh, you guys, this isn't rocket science. Why? Let's advocate for them. Let's go back and say, hey, listen, every time we start those freaking medicines, we have bad outcomes. Can we look at a whole panel of lab work on nutrient levels and seek to optimize those to see if it can make a difference? Can we do a nutrient challenge with high-dose omega-3 because we know how powerful they are in the brains of our seniors? I would propose an alternate method. Let's actually look for the root causes of dementia. Let's do some root cause problem solving. Let's strive to change the nutrient level and the micronutrient support with the very intentional use of supplements. I'm not talking about running down to the Walmart and getting the cheapest supplement you can find. What I'm talking about is doing an omega-3 level and then having the doctor give a concentrated amount of omega-3. It comes in liquid form or capsule form. We actually have seen big changes when we do this. I'm saying let's use vitamin E. Let's use vitamin B1, a high-dose thiamine that's used in chronic alcoholism that we know crosses the blood-brain barrier. Let's optimize folic acid level, which has now been linked to autism And the government's given indications, hey, maybe we need to use more folic acid in our pediatric patients who are struggling with the spectrum disorders. Oh my gosh, if it can improve the lives of a 12-year-old, it most certainly can improve the lives of an 82-year-old. And when we do that, it's fascinating how we get improved behaviors. Now they're not beating us up at night. They have better moods. We didn't even have to start an antidepressant. We just optimized the nutrients that are getting into the brain. And now, instead of being an angry old person, they're just kind of a pleasantly confused senior citizen. Their aging gets a little bit better. The way they age seems to be a little bit more graceful. And we have less and less need for these transport them to the emergency department because they're, transport them to the psych nurse practitioner because we need more antipsychotic medication to control their behaviors. No, 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 no. Listen, that's used far too often. We need to dig down more at the root cause level, right? So at A Mind for All Seasons, we have a very intentional protocol for how we address these behavioral problems, this advancing dementia. And it's beyond my ability to talk about all the details here, but I want you to know that we focus today on these elements. We're trying to improve the metabolic health with less sugar, less flour, less white processed foods that are totally robbed of nutrient levels. And we're much more focused on drawing lab levels of thiamine, vitamin B1, folate, vitamin B9, vitamin B12. What's their omega level, their vitamin D, their vitamin E, their selenium level. Let's look at glutathione, copper, and zinc. Let's focus on the things that make a difference and challenge those. We don't put them on a nutrient supplement and see behavior modification in one day, like we would if we give an antidepressant and we sedate them and they go to bed and then slobber all over themselves because they got tardive dyskinesia. We do these nutrient supports and slowly over a couple of weeks, we say, wow, this senior stopped swearing at me. They stopped kicking their caregiver. They stopped biting. Now they're coming out of the room. They're not isolated anymore. They're starting to use full sentences instead of just one word sentences. They recognized their daughter and called her by name when she came to visit. These are the testimonials that we hear on a daily basis. These are the case reports that we have been told for 10 years. I'm speaking from a perspective of clinical experience in taking care of seniors, and I invite you to be a part of the solution, to advocate for the seniors. Let's request more nutrient checks in our seniors and advocate for the right nutritional supplements that can make their lives better.